السلام عليكم ورحمة الله وبركاته. طلاب المرحلة الثانية كلية الصيدلة جامعة بابل. Our topic today is adrenal gland. Adrenal glands are small bilateral structures that weigh approximately 5 grams each and lie retroperitoneally at the apex of each kidney. The medulla or inner portion of the gland secretes epinephrine and norepinephrine and is part of sympathetic nervous system. The medulla contribute for 20% of the gland, while the other part, the cortex, form the bulk of adrenal gland, which form 80% of the gland and is responsible for secreting 3 types of hormones. The main hormones that are secreted from the cortex are the glucocorticoids, the mineralocorticoids, and the adrenal sex hormones, which are the androgens. Because the sympathetic nervous system also secretes epinephrine and norepinephrine, adrenal medullary function is not essential for life, but adrenal cortical function is essential for life. This figure demonstrates the cortex and medulla of the adrenal gland. As you can see, the main function of the medulla is producing epinephrine and non-epinephrine, while the cortex have 3 parts, which are the zona granulosa, which secrete mineralocorticoids, and the zona fasciculata, which secrete glucocorticoids, and the zona reticularis, which secrete androgens. In a table, the layer, its name, and its primary product. How these hormones are synthesized and transported. More than 30 hormones are produced by the adrenal cortex. Of these hormones, aldosterone is the principal mineralocorticoid. Cortisol is the major glucocorticoid, and the androgen are the chief sex hormones. All of the adrenal cortical hormones have similar structure in that all are steroids and are synthesized from acetate and cholesterol. Each of these steps involved in the synthesis of various hormones require specific enzyme. The secretion of glucocorticoids and adrenal androgens is controlled by the adrenocorticotropic hormone, which is secreted by the anterior pituitary gland. As you see, the adrenocortical steroids are made from cholesterol. Each one is made from cholesterol with some differences that make this hormone is specific and not similar to other hormones. How? Example, a progesterone will undergo a hydroxylation at C21 and will be converted into 11-deoxycorticosterone. Another 2 further hydroxylation at C11 and C18 will produce aldosterone. As you see, we start with progesterone, which undergo hydroxylation reaction at different parts, and the result is aldosterone. Another example, progesterone will undergo hydroxylation at C17, producing 17-alpha hydroxyprogesterone. Another hydroxylation at C21 will produce 11-deoxycortisol, and another step of hydroxylation at C11 will produce cortisol. As you see, we start with progesterone and end with cortisol. We use the same product, we use the same substance to produce different products. Cortisol and adrenal androgens are secreted in an unbound state. They will bind to plasma proteins for transport in the circulatory system. Cortisol binds largely to corticosteroid binding globulin and to a lesser extent to albumin. So the first binding protein that cortisol will bind to it is the corticosteroid binding globulin, while a lesser extent it will bind to albumin. Aldosterone circulated in the circulation mostly bound to albumin, and it has been suggested that the pool of protein-bound hormones may extend the duration of their action by delaying the metabolic clearance of these hormones. The main site for metabolism of adrenal cortical hormones is the liver, where they undergo a number of metabolic conversion before being conjugated and made water soluble. They are then, after they are made water soluble, they will be eliminated either in urine or in bile. An important hormones that are secreted from the adrenal gland are the adrenal sex hormones, which are synthesized primarily by the zona reticularis and the zona fasciculata of the cortex. These sex hormones probably exert a little effect on the normal sexual function. However, there is evidence that the adrenal sex hormones, the most important of which is the dihydroepiandrosterone, contribute to the pubertal growth of the body hair, particularly pubic and axillary hair in women. They also may play an important role in steroid hormone of pregnant women and the fetal placental unit. As we continue, mineralocorticoids play an essential role in regulating potassium and sodium level and a water balance. From their name, mineralo, they regulate the sodium, potassium, and water balance in the body. The most important of these mineralocorticoids is aldosterone. They are produced from the zona glomerulosa and the outer layer of the cell of the adrenal cortex. Aldosterone secretion is regulated by the renin-angiotensin mechanism, as you remember from the first course, and by blood level of potassium. The most important regulatory mechanism for aldosterone secretion is the renin-angiotensin mechanism and the plasma level of potassium. An increased level of aldosterone promotes sodium retention by the distal tubules of the kidney while increasing urinary loss of potassium. The most important effect of aldosterone on the tubular system in the kidney is retention of sodium and increased urinary excretion of potassium. Aldosterone causes potassium to be secreted into the tubules in the exchange for sodium reabsorption in specialized cells called principal cells. As you remember, these principal cells are present in the renal collecting tubules and also cause secretion of hydrogen ion in exchange for sodium in the intercalated cells of cortical collecting tubules. When there is excess secretion of aldosterone, it will cause an increased extracellular fluid volume and arterial pressure, but has only a small effect on plasma sodium concentration. It will cause hypokalemia because it increases the secretion of potassium in urine and also cause muscle weakness. Excess aldosterone also increases tubular hydrogen ion secretion and cause mild alkalosis because the loss of hydrogen. The third and important hormones that are secreted by the adrenal gland is the glucocorticoid hormones. The main and the most important hormone of which is cortisol. These hormones are synthesized in the zona fasciculata and the zona reticularis of the adrenal gland. The blood level of these hormones are regulated by negative feedback mechanism of hypothalamic pituitary adrenal system. How? The hypothalamus releases corticotropin releasing hormone, which is important in controlling the release of adrenocorticotropic hormone from the pituitary gland. We start by the hypothalamus, which releases the corticotropin releasing hormone, which will act on the pituitary gland to control the release of adrenocorticotropic hormone. Cortisol levels increase as the adrenocorticotropic hormone level rise and decrease as the ACTH level is fall. This figure demonstrates the hypothalamic pituitary adrenal pathway and the effect of feedback mechanism on the secretion of adrenal cortisol. The main important factor that stimulates the hypothalamus to produce the corticotropin releasing hormone is stress, infection, pain, hypoglycemia, trauma, hemorrhage, and sleep. As you can see, all these are stressful mechanisms. All these are stressful mechanisms which stimulate the hypothalamus, the anterior pituitary, and the adrenal cortex to produce cortisol, which is the stress hormone. There is considerable diurnal variation in ACTH level, which reach their peak in the early morning or around 6 to 8 a.m. and decline as the day progresses. This appears to be attributed to rhythmic activity of the CNS, which cause bursts of corticotropin releasing hormone secretion and in turn the ACTH secretion. This diurnal pattern is reversed in people who work during the night and sleep during the day. What do we mean this diurnal pattern is reversed? It will increase the corticotropin releasing hormone in the night, not in the evening, and this will increase secretion of ACTH also in the night, not in the morning. The rhythm also may be changed by physical, psychological stress, endogenous depression, manic depressive psychosis, and liver disease. That is why patients with endogenous depression or manic depressive psychosis will have sleep deprivation. Other conditions that affect cortisol metabolism can affect this diurnal rhythmic activity. One of the earliest signs of Cushing syndrome is disorders of cortisol excess is the loss of diurnal variation in the corticotropin releasing hormone and the adrenocorticotropic hormone secretion. And we will have a complete discussion about Cushing's syndrome later in this lecture. This figure demonstrates the diurnal variation of the plasma adrenocorticotropic hormone and the glucocorticoids. And as you see, there is a high production of the adrenocorticotropic hormone during the early morning, while there is a decline in its concentration and as well as a decline in the production of glucocorticoids in the evening. The glucocorticoids perform a necessary function in response to stress and are essential for survival. When produced as part of stress response, these hormones aid in regulation of metabolic function of the body and in controlling inflammatory response. How? Cortisol stimulates glucose production by the liver, promote protein breakdown, and cause mobilization of fatty acids. As body proteins are broken down, amino acids are mobilized and transported to the liver. In the liver, they will be used in production of glucose in a process called gluconeogenesis. While mobilization of fatty acids converts cell metabolism from the use of glucose as a source of energy to the use of fatty acids. As glucose production by the liver increase and peripheral glucose use decrease, a moderate resistance to insulin will develop. In persons with diabetes and those who are prone to diabetes, this has the effect of raising blood glucose level. As you see, the cortisol will have many effects on many cell types in the body. On muscle, it will increase protein degradation, decrease protein synthesis, decrease glucose utilization, and decrease sensitivity of the cells to insulin. That is why patient will have insulin resistance. These proteins, which are degraded, will convert it into amino acids that will pass in the circulation into the liver to produce glucose by gluconeogenesis. It will also, cortisol, affect the adipose tissue, cause lipolysis, decrease glucose utilization, and decrease sensitivity to insulin. And by this way, it will result in insulin resistance. While glycerol, which are produced by lipolysis, will pass into liver. In the liver, it will convert it into glucose, so increase glycogen storage, increase gluconeogenesis by activity of enzymes, and increase the amount of enzymes required for this process. As we talked before a few minutes, it will stimulate release of amino acids from the body, stimulate lipolysis, and stimulates gluconeogenesis and the production of glucose from newly released amino acids and lipids. It increases blood glucose level in response to stress by inhibiting glucose uptake into the muscle and fat cells. By this mechanism, it inhibits glucose uptake into muscles and cells. By this mechanism, it will produce increase in insulin resistance. Cells insulin resistance. What is the psychological effect of glucocorticoids hormones on our body? It appears to be involved directly or indirectly in emotional behavior. Receptors for these hormones have been identified in the brain tissue, which suggests that they play a role in the regulation of behavior. Persons treated with adrenal cortical hormones have been known to have a display behavior ranging from mildly apparent to psychotic. What is the role of our body to respond to stress? There's two roles for our body to respond to stress. There is a short-term stress response and a long-term stress response. When there's a stressful condition, there will be a stimulation of the hypothalamus, which will produce the corticotropin releasing hormone, which stimulate the pituitary production of ACTH from the anterior pituitary. Directly, the ACTH will pass in the circulation into the adrenal cortex and stimulate the production of mineralocorticoids and the glucocorticoids. This is the long-term stress response, which results in retention of sodium and water by the kidney, increase blood volume and blood pressure. It will cause the protein and fat converted into the glucose and breakdown for energy, and increase blood sugar, and there will be suppression of immune system due to the production of the cortisol hormone. This is the long-term stress response. While the short-term stress response will have stimulation of the hypothalamus, which will directly stimulate the nervous system. It will pass nerve impulses into the spinal cord through the preganglionic sympathetic fibers. It will pass into the adrenal medulla. So, in the short-term stimulation, there is sympathetic nervous system activation. There's sympathetic nervous system activation. Okay? There will be stimulation of the adrenal medulla to produce the catecholamines, which are epinephrine and norepinephrine. And as you know, they will increase heart rate, blood pressure, and will stimulate the liver to convert glycogen to glucose and release glucose to the blood. And they will cause dilatation of the bronchioles, change in blood flow pattern lead to increased alertness and decrease the digestive system activity, reduce the urine output, and also it will increase the basal metabolic rate. Cortisol also have influence on the immunological system and the inflammatory responses of the body. Cortisol blocks inflammation at an early stage by decreasing capillary permeability and stabilizing the lysosomal membranes so that inflammatory mediators are not released. It also suppresses the immune response by reducing the humoral and cell-mediated immunity. With this, it will lessen the inflammatory response and reduce fever. During the healing phase of inflammation, cortisol suppresses fibroblast activity and thereby it will lessens the scar formation. Cortisol also inhibits prostaglandins synthesis, which may account in large part for its anti-inflammatory action because prostaglandin is inflammatory mediator. When large quantities of cortisol are required for an effective anti-inflammatory action, this is achieved by administration of pharmacological rather than physiological doses of synthetic cortisol. As you see, we can use cortisol as a pharmacological preparation for treatment of some inflammatory actions in the body. Other effects of cortisol, it strengthens cardiac muscle contractions, increase water retention, assess lung maturation and surfactant production, as you remember from the first course. It is important for the maturation of the lung and production of surfactant, and also cortisol increase gastric acid secretion. As you see, the action of cortisol is illustrated in this table. Now, what happens is if there is adrenal cortical insufficiency. There are two forms of adrenal insufficiency. The primary adrenal insufficiency, or which is called Addison's disease, which is caused by destruction of adrenal gland, and a secondary adrenal insufficiency which results from disorder of hypothalamic pituitary adrenal system. Either it is a primary cause which occur in the adrenal gland itself, or it is secondary insufficiency which may result from a defect in any part of this system, which is the hypothalamic pituitary adrenal system. As you see in the figure, this is a patient with Addison disease. Hyposecretion of adrenocorticotropic hormone from the anterior pituitary result in decreased production of glucocorticoids and mineralocorticoids from the adrenal gland, result in hypotension and hypoglycemia. It results in symptoms of hypotension and hypoglycemia. How we treat these patients? Corticosteroid replacement therapy is the most important treatment for these patients. A primary adrenal insufficiency in which adrenal cortical hormone are deficient and the adrenocorticotropic hormone level are elevated because the lack of feedback inhibition from the adrenal gland. So, in the primary adrenal insufficiency, there is decrease in adrenal cortical hormones and increase in level of ACTH hormone. Why? Because the lack of feedback inhibition. All the layers of adrenal cortex are destroyed, either by autoimmune disorder, which cause autoimmune destruction in the gland, which is the most common cause and called Addison disease. Other causes other than the autoimmune destruction is tuberculosis, metastatic carcinoma, fungal infection, cytomegalovirus infection, amyloid disease, and hemochromatosis. It is a chronic metabolic disorder that requires a lifetime hormonal replacement therapy. Mineralocorticoid deficiency causes increase in urinary loss of sodium, chloride, and water, along with decreased excretion of potassium. The result is hyponatremia, loss of extracellular fluid, decreased cardiac output, and hyperkalemia. There may be an abnormal appetite for salt because the patient is in need for salt. Orthostatic hypotension is common. Also, the patient may have dehydration, weakness, fatigue, and if the loss of sodium and water is extreme, cardiovascular collapse and shock may occur. Deficiency of glucocorticoids causes the person with Addison disease to have poor tolerance to stress. This deficiency causes hypoglycemia, lethargy, weakness, fever, gastrointestinal symptoms such as anorexia, nausea, vomiting, and weight loss. As you see in the last figure, there is hyperpigmentation in the face of the lady. Why? Hyperpigmentation results from elevated level of ACTH. The skin looks bronzed or sun-tanned in exposed and unexposed area. In exposed and unexposed area, and the normal creases and the pressure points tend to become especially dark. The gums, oral mucosa membranes may become bluish black. The amino acid sequences of ACTH is strikingly similar to that of melanocyte stimulating hormone. So, hyperpigmentation occurs in more than 90% of persons with Addison's disease and is helpful in distinguishing the primary and secondary form of adrenal insufficiency. Why we can distinguish the primary and secondary form of adrenal insufficiency by this hyperpigmentation? Because this hyperpigmentation occurs because of increased level of ACTH. Treatment is replacement therapy with higher doses being given during periods of stress. Hydrocortisone usually is the drug of choice. Regular schedule for meals and exercise so that we can maintain the normal blood glucose level. All persons with Addison's disease should be advised to wear medical alert bracelets or needle. Why? When these persons are exposed to stressful condition and they develop hypoglycemia or hypotension, so this medical alert bracelets or needle will give us an idea that this person is Addison's disease patient. So now we will learn about the secondary adrenal cortical insufficiency. Secondary adrenal insufficiency can occur as a result of hypopituitarism or because the pituitary gland has been surgically removed. The cause is not in the adrenal gland. So this will result in decreased level of ACTH hormone, the adrenocorticotropic hormone, which released from the anterior pituitary gland. It will not cause hyperpigmentation and do not cause hyperkalemia or acidosis because aldosterone level is normal. Symptoms similar to Addison's disease. Tertiary adrenal insufficiency results from hypothalamic defect. The defect here is not in the adrenal gland, not in the pituitary gland. The defect is in the hypothalamus. However, a far more common cause than either of these is the rapid withdrawal of glucocorticoids that have been administered therapeutically. These drugs suppress the hypothalamic pituitary adrenal system with resulting adrenal cortical atrophy and loss of cortisol production. This suppression continues long after drug therapy has been discontinued and can be critical during periods of stress or when surgery is performed. Another form of adrenal gland disorders is Cushing's syndrome. An increased level of cortisol in the body will cause a pathological condition called Cushing's syndrome. It refers to the manifestation of hypercortisolism from any cause. As we talk about the causes, there are three important forms of Cushing's syndrome. Result from excess glucocorticoids production by the body. The first is the pituitary form, which results from excess production of ACTH hormone by a tumor of pituitary gland. This form of the disease was the one originally described by Cushing. Therefore, it is called Cushing's disease. The second form of the disease is the adrenal form, which caused by a benign or malignant tumor of the adrenal gland. The first is pituitary form, the second is adrenal form, while the third is the ectopic Cushing's, which is caused by non-pituitary ACTH secreting tumor, a tumor that presents anywhere in the body and produce the adrenocorticotropic hormone, which will pass in the circulation and act on the body, but it is not secreted from the pituitary gland. As you see in the figure, the same boy when he was normal and when he developed Cushing's disease. Cushing's syndrome also can result from long-term therapy with one of the potent pharmacological preparations of glucocorticoids. This form is called iatrogenic Cushing's syndrome. Iatrogenic, it means it is caused by pharmacological preparation of glucocorticoids, not produced by the body. So it is called iatrogenic Cushing's syndrome. How these patients appear? Patient will have protruding abdomen, subclavicle fat pads or buffalo humps on the back and around a plethoric moon face. The extremities are thin because of protein breakdown and muscle wasting. Extremities, I mean the upper and lower limbs. Purple striae or stretch marks from stretching of catabolically weakened skin and subcutaneous tissue are distributed over the breast, thighs, and the abdomen. Osteoporosis might develop because of destruction of bone proteins and alteration in calcium metabolism, result in back pain, compression fractures of the vertebrae, and ribs fractures. As calcium is mobilized from the bone, renal calculi may develop. Hypokalemia, diabetes, and hypertension. Increase susceptibility to infection and increase in androgen level cause hirsutism, mild acne, and menstrual abnormalities in women. As you see, this is the shape of patient with Cushing syndrome. Thank you very much for your attention, and I will see you in the next lecture.